Bismillahirrahmanirrahim. Today we will have case quiz number 102. Case data: 47 years old white right-handed male, complaining of abrupt onset of left leg numbness while he was at work. He walked around to try to restore circulation when it suddenly became paralyzed and noticed his left arm and leg began to contract rhythmically and involuntarily. So involuntary movement and numbness with paralysis, sudden onset, with no eye deviation, face involvement, or loss of consciousness. Movement stopped at the time of arrival to the hospital, few minutes later, with no history of seizures or stroke. Past medical history was significant for migraine headaches, sinus allergy, chronic uveitis, and parathyroidectomy. He had an episode of severe uveitis at age of 8 with bilateral eye redness and soreness, and was treated with steroid and cytoxan or endoxan cyclophosphamide. His medications were oxymetazoline nasal spray for nasal congestion and daily prednisolone eye drops. He had 20 years history of tobacco use and drinks alcohol socially on occasions. No unusual exposure history and never exposed to TB and proved to be negative for TB later on. Family history of mother with breast cancer and sister with Sjogren syndrome who had uveitis as well. So his mother had breast cancer and his sister had Sjogren and uveitis. Examination: the vital signs were unremarkable. The patient was awake, alert, and following commands. Physical and radiological exam was only remarkable for decreased sensation to light touch on the left lower extremity. Investigations and initial management include CBC and metabolic panel were all within normal levels. MRI of the brain demonstrated an intraaxial mass in the post-central gyrus measuring 2.7 by 1.5 by 2.2 centimeters. It was slightly hyperintense on T1, enhanced with gadolinium peripherally, and hypointense on flare with surrounding edema. CT scan of the chest, abdomen, and pelvis demonstrated paraesophageal and mediastinal adenopathy with calcifications and was otherwise negative. He was started on phenytoin 100 mg TID and dexamethasone 8 mg IV 4 times daily. Given his history and the clinical findings, he was felt to most likely have metastatic disease to the brain, and resection was recommended. A craniotomy was performed with resection of the right parietal brain mass. Histological examination of the resected specimen show cerebral gray and white matter. At the gray-white matter junction, multiple non-caseating granulomas were identified. The adjacent gray and white matter showed reactive gliosis, but no evidence of neoplastic process was noted. Scattered blood vessels with perivascular lymphocytes were also present, including the leptomeninges. Each granuloma had composed of histiocyte with a peripheral rim of benign lymphocyte which were further characterized as T cell using immunohistochemistry for CD3. Because of the presence of perivascular lymphocytic cuffing, vasculitis of the CNS was considered. However, it was ruled out by the absence of fibrinoid necrosis. Another important diagnosis that needed to be ruled out was lymphoproliferative neoplasm involving the CNS. while angiocentric lymphocytic infiltrate is a common finding in lymphoma of CNS. The lymphocyte looked cytologically normal and the flow cytometry showed no clonal lymphocytic population, so cancer is also excluded, and TB, I said before, was excluded from the start. So, what is the diagnosis? And as usual, we will leave you for 6 days, and the answer will be online on next Thursday. Wassalamu alaikum wa rahmatullahi wa barakatuh.